Here we are back in week 2 again. Everybody's favorite subject is the pneumonias. This seemed to be a really big pneumonia year, and there is once again certain ways that you treat people with pneumonia. It matters on their comorbidities, all their risk factors. Are they a smoker? Are they a child? Are they pregnant? All different things. Are they a teenager? Are they living in a dorm? Are they homeless? All those different things when you have a patient sitting in front of you who has symptoms of pneumonia. So first we're going to look at the pathophysiology of it all. Just is an organism that invades the lung parenchyma. Usually it can come after people are sick, even with a viral illness as flu, and then all of a sudden they haven't gotten better and it's gone into a pneumonia. That's one reason why flu epidemics are so serious. People don't tend not to get over influenza, and it can go right into the pneumonia. So the viral then turns into a bacterial problem. You always want to watch your elderly and your very young, of course, your chronically ill patients, your cancers, your COPDers. COPDers and smokers are the people that you really want to watch the most for your pneumonias in your clinical practice. Your goals of treatment, of course, are they want to return to their baseline respiratory status. With that being said, you're not going to get a normal x-ray for 4 weeks out. So sometimes it's not even worth repeating if your patient is showing improvement. The fever usually resolves in 2 to 4 days, providing that your patient really does have a fever. There's many, many patients who do not have fevers with pneumonia, even though that is one of the main symptoms. Leukocytosis, so if you have quite a high white count, that should be decreasing on day 4 of treatment. But to be truthful, if your patient clinically is improving by day 4, you're not going to repeat the chest x-ray, you're not going to repeat a CBC, either one. You're just going to, you need to follow the person that's in front of you, the clinical presentation of the patient. Okay, so common adult pathogens for this. Strep pneumoniae is the most common pathogen in all pneumonias for everybody, pretty much, but definitely it definitely is the most common in the adult population. Once again, usually have underlying lung disease when they get this. There's H flu, and then there's the MC, and that's usually what the smokers get. Staph aureus is a co-pathogen sometimes with influenza. Mycoplasma pneumoniae is what you're going to see in kids who are in daycare centers or dorms, older kids in dorms, and of course then there's viral pneumonia. That's not going to get any better except with inhalers and steroids. Okay, so you have your adult community-acquired pneumonias, and that's usually, you have type 1, your patient is usually healthy and has strep pneumoniae. Type 2 is patients with risk factors. 3, not admitted to the ICU but in the hospital. 4, your ICU. Those are your different types. So your treatment. When you have your healthy adult who presents 30 years old, has no risk factors, but you can tell you have got bilateral diminished breath sounds, you have dullness to percussion, you've got bilateral bronchi in upper and lower lobes. They're level 1 evidence, so that's a macrolide. Believe it or not, a lot of us are just sick of prescribing Z-Paks, I'm sure, but Z-Pak, actually azithromycin, is standard of care in a healthy adult with pneumonia. You can use clarithromycin or erythromycin as well. Erythro is very hard on the stomach. Clarithrol reacts with every medication known to man, so actually azithromycin is not really a bad drug. And as far as pneumonia goes, and some bronchitis, it's not to be poo-pooed. As far as other things, I wouldn't waste my time. I don't really care for it much for sinusitis. Okay, so if you have a patient who is allergic to a macrolide, of course, you always can give Doxy. Doxy is another drug that people tend to overlook. Doxy is a great drug. It's good for a whole lot of things. And actually, you'll have a patient that comes in with a couple of things going on, maybe not just the pneumonia, and Doxy can treat a multitude of things. You always want to save your bigger drugs for something else, like a Levaquin for somebody with comorbidities. Okay. So once again, azithromycin, treat for the minimum of 5 days. That is what a Z-pack is. They do sell tri-packs actually, except the problem with the tri-pack is it's a 3-day treatment. So it's actually 500 milligrams times 3 days. If you do feel the need to use a tri-pack, you need to write it for 6 days, or you need to use put a refill on it. Adults with comorbidities or at risk for drug resistance. Drug resistance comes from when you have a patient who you've treated with sinusitis and now all of a sudden they've come to you with a pneumonia. You're most likely not going to be able to treat that patient with azithromycin. You're going to have to treat that patient even if they're a healthy 30-year-old with Levaquin, because now you've caused a drug resistance because they've just come off a antibiotic. Very rarely are you going to treat somebody with an augmentin for a sinus infection. They're going to come back to you now with a pneumonia, and you are not going to, most likely not going to have success with azithromycin. Okay. The other thing that you can treat with when you do have adult with comorbidities or drug resistance, if you don't want to use Levaquin, anything with a beta-lactamase plus a macrolide. So that's amoxicillin or augmentin, your cephalosporins, and you can always give a shot of ceftriaxone followed by a ceph. Doxy, once again, is always a great drug, and it's an alternative to a macrolide. Okay, so if you give 1 gram of Rocephin IM, and then, or you can give levofloxacin 500 milligrams IV daily for patients in the hospital, but for outpatient treatment, you're not going to do that. But I have actually, in the assisted living facility, I had somebody come down with a really bad pneumonia really quick. She was a compromised patient. She had had lung cancer at one point. I believe she was 86 years old. She was actually there. Actually, she has critical aortic stenosis, and she was just rehabbing from muscle weakness. Shouldn't have been in the facility, by the way. Anyway, comes down with a really bad pneumonia, and I knew that just oral levofloxacin, I was giving her 750 milligrams PO daily, wasn't going to do it right away, so I gave her a shot of ceftriaxone Rocephin right away in the facility and then started the oral med, and it did turn her around for a bit, but she's another story. She ended up having an empyema in her lung, and I ended up sending her out anyway. Okay, so if you have community-acquired pneumonia in a pregnant woman, it's usually strep pneumoniae, once again, H. flu, M. pneumoniae, or virus. So once again, macrolides. Pregnancy category B, you hardly ever find drugs that are pregnancy category B, but erythromycin is, and so is your good old Z-pack. So the pregnant woman would probably be really appreciative of the azithromycin instead of the erythromycin. As you can see, clarithromycin is a category C. What does category C mean? It means it's not been tested in the pregnant woman. That's all that means. It's been tested in animals, pregnant. So B, on the other hand, it has proven to be a safe drug. So that's all the difference that is. You're going to need to know the different categories and your pregnancy classes and what they mean. So if she has a comorbid condition, say she's a pregnant woman and she's a diabetic or a severe asthmatic, or she's had recent antibiotics, you can give her an augmentin plus a macrolide. That seems like a lot of medication though. Alright, so then we have the kids. You've got common pediatric pathogens. Once again, strep pneumoniae, huge board question, is the most common cause of bacterial pneumonia in all ages. Kids are vaccinated for PCV7 now for viral pneumonia, so we don't see as much of it. So whenever you have an infant who you're first of all, if you have a sick infant, you know you've got trouble to begin with. But infants 4 to 16 weeks come down with a pneumonia, you have a bad x-ray, you've got a fever, you've got a really sick baby, immediately your mind's got to jump to chlamydia. Okay, so we put those erythromycin eye drops in the baby's eyes, and we think it's for chlamydia and gonorrhea, but guess what? It's really not. It's just for the gonorrhea. So chlamydia, if the baby did not present with an eye infection and and you didn't know the mother had chlamydia, all of a sudden you've got this sick month-old baby, which is big trouble. It's oral erythromycin is the treatment. Nowadays, though, you've got a sick baby with anything respiratory, please, 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 please check for pertussis. Many babies are dying of pertussis because we're not testing and we're missing it. Babies don't always present with that lovely cough. So kids over 5, you're going to consider through adolescence, and actually I don't even like adolescents, people that are living in dorms, consider mycoplasma for pneumonia because that's usually what it is. It's usually not strep pneumoniae over 5. The kids are sitting in classrooms and just passing it back and forth. So if you've got strep pneumoniae, you've got kids under 5, you're going to treat with a MOX, just 80 to 90 per kilo, or Ceph, and it's 50 per kilo. And it usually works really well. If you have kids with a penicillin allergy, Clinda or a macrolide works great. Once again, a Z-Pak. Kids actually do take Z-Paks. They're not the same. It's oral dosing. Or Clinda. Clinda is really rough on the stomach where the Z-Pak isn't. And once again, if you have that chlamydia pneumonia, you want to treat for 14 days. So when you have kids 5 or older, you're looking at your mycoplasma or anything atypical. So azithromycin, perfect drug for that. Once again, I'm probably the biggest basher of the Z-Pak, but here it is, standard of care. Okay, so what you want to teach your patients are pneumonia might be bacterial, viral, or mycoplasma, right? So hydration, 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 smoking cessation. If you don't want the parent smoking, you don't want the patient smoking. Once again, we need to educate patients on really finishing all their medication. That doesn't always happen either, or not to share it. I just had a patient come in the other day. It's the wrong lecture, but I'll bring it up anyway. I had diagnosed her husband with strep. I guess her child had strep. She was feeling a little ill. She started taking her husband's Amox. Then she comes to me the other day, and I have a perfect normal exam in front of me, negative strep test, and now what am I supposed to do? Which is kind of what I explained to her. So I end up prescribing her 10 days of Amox so she could give her husband back his 3 days of Amox. And I'm not sure if I'm really treating her appropriately or not, if she really needed it or not. So these are the kind of things that you also need to troubleshoot in clinical practice. I was really hesitant to give her anything at all, and the main reason that I did was she's having a dental/sinus procedure done on Friday. Anyway, but that is pretty much, I think, the pneumonias in a nutshell. I mean, the most things for clinical practice that you need to know is, are you treating anybody with comorbidities, or are you treating somebody who's fairly healthy? Fairly healthy individuals usually respond really well. The biggest thing is, though, if you have somebody with comorbidities, there is a very nice cocktail that works, and sometimes even I'll do it if somebody's pretty sick. You can go ahead and we'll go with no comorbidities, no smoking. You give your Z-Pak, and I'll give 20 milligrams of prednisone BID for 5 days. No need to wean. That's kind of, I don't know if you're seeing that in clinical these days, but it's kind of an old practice to have to wean. If you're giving 40 milligrams of pred every day for 5 days, there is absolutely no need to wean at all. So once again, this is a great cocktail, either the azithromycin, your Z-Pak, with 40 milligrams of prednisone for 5 days, and then to stop the prednisone, or Levaquin. So the prednisone and the Levaquin really is the best cocktail. So it's Levaquin, 750 milligrams. Somebody either has antibiotic resistance or comorbidities. I treat for 7 to 10 days, usually just 7 days. Levaquin's nice, it's once daily, and then once again give the prednisone 50 milligrams, 40 milligrams for 5 days, and then just stop it.